Hey everyone, this is Morgan Laborde, and I'm doing my presentation on atopic dermatitis, which is better known as eczema. Atopic dermatitis is a common inflammatory skin disorder with a chronic but intermittent disease course that typically presents in childhood, with approximately 50% of children diagnosed by age 1 and 85% by age 5. Adult diagnosis is less common, but about 26% of adults develop atopic dermatitis in their lifetime. The prevalence of atopic dermatitis is actually higher in African American children compared to their Caucasian counterparts. Its etiology is very complex, as there is not one clear pathology associated. Instead, there are several proposed genetic and environmental factors that can contribute to its development. Patients with atopic dermatitis have a dysfunctional skin barrier, which allows water to easily escape and irritants to enter. In addition, these patients also have an abnormal immune response due to a dysregulation of T helper cells, causing their skin to be easily irritated and prone to developing infections. Recent research has found a genetic mutation in the filaggrin gene, which is responsible for creating the flat and tightly packed epithelium, which may cause the skin barrier dysfunction. A family or personal history of atopy, which includes asthma, food allergies, or allergic rhinitis, predisposes one to the development of atopic dermatitis. The classic presentation of atopic dermatitis involves a combination of erythema, edema, papules or papulovesicular lesions that ooze, crest, and scale over. It is important to keep in mind that this classic presentation of atopic dermatitis is what occurs in those with white skin. In African Americans or those with dark skin, it will appear more as pityriasis alba, which is white or slightly depigmented areas that are crested or scaled over, as seen in the bottom picture. Distribution can also vary by age, with children having atopic dermatitis more widespread to include the face and torso. Adults typically have the classic distribution, which involves the flexural folds of the knees, elbows, wrists, and neck being the most commonly involved areas. However, regardless of age, the most bothersome and major symptom of atopic dermatitis is pruritus, or itching, with the severity of the itching correlating to the severity of the disease. Excessive scratching can cause lichenification, or a thickened and excoriated appearance of the skin. There are scoring scales that can be used to help the clinician quantify the severity of a patient's atopic dermatitis. However, these scales are more commonly used in clinical trials rather than in clinical practice. Diagnosing atopic dermatitis is a clinical one based off patient presentation, the presence of the characteristic lesions in the classic distribution, and exclusion of other conditions with similar presentations. It is important to exclude other diagnoses that can present similar to atopic dermatitis, such as contact dermatitis, seborrheic dermatitis, scabies, or psoriasis. A gold standard tool that can aid in the diagnosis is the Hanifin-Rajka criteria, which is pictured here on the left. 3 of the major criteria and 3 of the minor criteria must be met to diagnose atopic dermatitis. The most important component in the treatment of atopic dermatitis is daily use of emollients or moisturizers, especially after bathing, and avoidance of any known triggers. Topical corticosteroids are used in adjunct to moisturizers to help with symptom relief. Selection of the topical corticosteroid is done in a stepwise approach based on the patient's disease severity. Those with mild disease can be treated with an as-needed or daily use of a low-potency topical corticosteroid, or TCS for short. Those with moderate disease can benefit from the regular use of a mid-potency topical corticosteroid, such as triamcinolone. Severe or acute flares can be treated with temporary use of a high-potency TCS that is reduced once there is symptomatic improvement. Atopic dermatitis that involves the face, genitalia, and/or androgynous areas should only be treated with a topical calcineurin inhibitor, pimecrolimus cream, or tacrolimus ointment. Severe or refractory atopic dermatitis can be treated with other topical add-ons or via other methods. For example, crisaborole or Eucrisa is a topical non-steroidal PDE4 inhibitor that is approved for children 3 months and older. Dupixent is a subcutaneous monoclonal antibody injection approved for those 6 months and older. UVB therapy is typically reserved for adults only who have severe disease that does not respond to topical therapies. Keep in mind that young children should only receive low or mid-potency steroids. Very high or high potency can only be used for 1 to 2 weeks and then should be stopped or changed to a lower potency. Those who have atopic dermatitis that is refractory to topical therapy should be referred to a dermatologist, as they would be the one to perform phototherapy or systemic therapy. Here is a chart of some of the topical corticosteroids broken down by potency and vehicle. Please note that this list is not exhaustive, and a full list of topical corticosteroids is available and can be found on UpToDate. Here are a list of my references. Thank you guys so much for watching. I hope this was very informative and you guys were able to learn something new about atopic dermatitis.